Welcome to the February 2018 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the February issues of the journal, as well as commentaries by Dr. Timothy A. Damron on the article entitled An Easy-to-Use Prognostic Model for Survival Estimation for Patients with Symptomatic Long Bone Metastases, and Dr. Raphael J Sierra on the article entitled Lowdose Epinephrine plus Tranexamic Acid Reduces Early Postoperative Blood Loss and Inflammatory Response, a randomized controlled trial. Be sure to check out this month's Current Concepts Review article, The Role of Extracorporeal Shockwave Treatment in Musculoskeletal Disorders, by Daniel Moya and colleagues. The authors note that increasing evidence suggests that extracorporeal shockwave treatment, ESWT, is safe and effective for treating several musculoskeletal disorders. Strong evidence supports the use of ESWT in calcifying tendinopathy of the shoulder and plantar fasciitis. The best evidence for the use of ESWT was obtained with low to medium energy levels for tendon disorders, as well as with a high energy level for tendon calcification and bone pathologies in a comprehensive rehabilitation framework. In this issue, JBJS.org presents a new image quiz of 52-year-old man with thigh pain following an accident. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled An Easy-to-Use Prognostic Model for Survival Estimation for Patients with Symptomatic Long Bone Metastases by Dr. J.J. Willemier and Associates. Investigation performed at Leiden University Medical Center, Leiden. University Medical Center, Groningen, Groningen. University Medical Center, Utrecht, Utrecht. Hoog Medical Center, The Hague. Reinier de Graaf Gasthuis, Delft. Erasmus Medical Center, Rotterdam, the Netherlands, and Medical University of Graz, Austria. A survival estimation for patients with symptomatic long bone metastases, LBM, is crucial to prevent overtreatment and undertreatment. This study analyzed prognostic factors for overall survival and developed a simple, easy-to-use prognostic model. A multi-center retrospective study of 1,520 patients treated for symptomatic LBM between 2000 and 2013 at the radiation therapy and/or orthopedic departments was performed. Primary tumors were categorized into 3 clinical profiles: favorable, moderate, or unfavorable, according to an existing classification system. Associations between prognostic variables and overall survival were investigated using the Kaplan-Meier method and multivariate Cox regression models. The discriminatory ability of the developed model was assessed with the Harrell-C statistic. The observed and expected survival for each survival category were compared on the basis of an external cohort. Median overall survival was 7.4 months, with a 95% confidence interval of 6.7 to 8.1 months. On the basis of the independent prognostic factors, namely the clinical profile, Karnofsky performance score, and presence of visceral and/or brain metastases, 12 prognostic categories were created. The Harrell-C statistic was 0.70. A flowchart was developed to easily stratify patients. Using cutoff points for clinical decision-making, the 12 categories were narrowed down to 4 categories with clinical consequences. Median survival was 21.9 months, with a 95% CI of 18.7 to 25.1 months. 10.5 months with a 95% CI of 7.9 to 13.1 months. 4.6 months with a 95% CI of 3.9 to 5.3 months. And 2.2 months with a 95% CI of 1.8 to 2.6 months for the 4 categories. Conclusions. This study presents a model to easily stratify patients with symptomatic LBM according to their expected survival. The simplicity and clarity of the model facilitate and encourage its use in the routine care of patients with LBM to provide the most appropriate treatment for each individual patient. Next, you'll hear a commentary by Dr. Timothy A. Damron on the article entitled, Is This Easy-to-Use Tool the Best Way to Predict Survival?
This is Dr. Timothy A. Damron providing commentary for the February 2018 JBJS podcast. I will be providing commentary on the article entitled, An Easy-to-Use Prognostic Model for Survival Estimation for Patients with Symptomatic Long Bone Metastases. The title of my commentary is this easy-to-use tool the best way to predict survival? Comparatively speaking, there are more tools for predicting survival in patients with spine metastases than with long bone metastases, but good tools are needed for each. The authors of this study felt strongly enough about this fact that they set out to develop a survival prediction tool for patients with long bone metastases based on their earlier work in the spine. To evaluate this tool, several criteria that define a good survival prediction tool can be examined. First, the data on which it is based must be robust and supported by valid statistical analysis. Second, a truly useful survival prediction tool is best if it is easy to use. Less is more here, and the variables should be easily accessible. Third, the tool should provide meaningful survival windows that contribute to clinical decision making. Unfortunately, there are at least three aspects to meaningful survival windows: recovery, durability, and economics. None have been studied adequately to date. Armed with these suggested definitions of a good survival prediction tool, the current tool can be evaluated. There are several strengths. First, the currently reported tool is backed by robust statistical support. Variables were the product of a very large derivation dataset of 1,520 patients, the resulting tool having been tested successfully in a validation group of 250 patients. Second, it would appear to be easy to use as it is based on only 3 variables. Third, for as much as is known about what we need for meaningful time prognostication, this tool does a good job at tightly separating the patients with very poor survival, median 2.2 months, from those with poor, median 4.6 months, fair, median 10.5 months, and best survival, median 21.9 months. A fourth and somewhat unique strength of this tool is its flexibility in allowing adjustment of the clinical profile according to changes in the prognosis for specific primary diseases over time. However, there are several weaknesses with this tool. The very nature of including only orthopedic and radiation oncology patients, while on the one hand representing an advance from other tools, excludes those managed primarily by medical oncology and confounds by indication, possibly biasing towards better prognosis than would have been observed if all patients were examined. There were also issues with accessibility of the 3 variables, as only 74% of patients had all 3 available. Only 76% had functional scoring available, and of those patients, 47% had scoring derived from chart descriptions. Of the other 53%, only approximately half had a Karnofsky performance score available, the remainder having World Health Organization scores instead. Translated, only 20% of the original derivation group had a Karnofsky performance score available. Prior studies have also shown high variability with respect to the Karnofsky performance scores. Beyond the study criticisms, the reported tool may simply not be so easy to use or even the easiest system available. A report examining bone metastases for the entire skeleton predicted survival with equivalent accuracy utilizing just 2 variables, Karnofsky performance score and primary tumor. Some might argue that a tool for the entire skeleton is more practical since it includes the pelvis, where procedures may require a longer recovery time than those of the extremity. Evaluation for brain metastases in this study was done almost exclusively without imaging and was based on clinical assessment. On the other hand, imaging to detect visceral metastases in this study was done in 97% of the patients. Hence, if one is to use this system, a thorough clinical examination to detect intracerebral lesions and imaging of the viscera should be done. Further, additional bone imaging should be obtained for renal cancers to stratify them within the two categories based on number of metastases. In summary, the proposed tool is based on a robust derivation database, is statistically valid, and derives from earlier models by this group that have utilized the same three variables for spine tumors, applying it now to long bones. It has unique advantages of including orthopedic and radiation oncology patients, excludes myeloma, and is independent of laboratory results. From an orthopedic perspective, the usefulness of tools such as this one awaits better understanding of typical recovery courses, durability, and cost-benefit analyses for internal fixation devices versus standard endoprostheses and megaprostheses. Further validation of this tool awaits testing on a larger prospective pool of patients.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Femoral Version Abnormalities Significantly Outweigh Effect of Cam Impingement on Hip Internal Rotation by Matthew J. Krautler and Associates. Investigation performed at the CU Sports Medicine and Performance Center, Department of Orthopaedics, University of Colorado School of Medicine, Boulder, Colorado. The purpose of this study was to investigate the effects of femoral version cam-type femoral acetabular impingement, FAI, and the combination of the two on the passive hip range of motion, ROM. The authors prospectively analyzed a consecutive cohort of 220 patients, 440 hips, who presented with unilateral or bilateral hip pain. The passive hip ROM was measured bilaterally with the patient in prone, supine, and lateral positions. Femoral version was measured, and the presence of cam-type deformity was determined on preoperative computed tomography, CT scans. Diagnostic findings of cam-type FAI included an alpha angle of greater than 50 degrees on CT radial sequences of the head-neck junction and a femoral head-neck offset ratio of less than 0.18 on both radiographs and CT. Multivariate linear regression analysis confirmed that femoral version, as compared with the presence of a cam lesion, was a stronger independent predictor of internal rotation ROM. Conversely, the presence of a cam lesion resulted in a significant decrease in the passive hip flexion ROM, P less than 0.001, with no additional effects due to the degree of femoral version. The passive hip internal rotation ROM in neutral flexion extension and with the hip in 90 degrees of flexion were maximized in patients with femoral anteversion and decreased significantly with each incremental decrease in femoral version, P less than 0.001. Conclusions. Abnormalities in femoral version significantly outweigh the effect of cam-type impingement on the passive hip internal rotation ROM. In contrast, the presence of a cam lesion significantly decreases the hip flexion ROM, irrespective of the degree of femoral version. These findings help to inform surgical decision-making for patients with cam-type FAI, or femoral version abnormalities. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Lowdose Epinephrine plus Tranexamic Acid Reduces Early Postoperative Blood Loss and Inflammatory Response, a randomized controlled trial by Dr. Weinan Zheng and Associates. Investigation performed at the Center for Joint Surgery, Southwest Hospital, 3rd Military Medical University, Chongqing, People's Republic of China. The reductions of perioperative blood loss and inflammatory response are important in total knee arthroplasty. Tranexamic acid reduced blood loss and the inflammatory response in several studies. However, the effect of epinephrine administration plus tranexamic acid has not been intensively investigated to the author's knowledge. In this study, the authors evaluated whether the combined administration of low-dose epinephrine plus tranexamic acid reduced perioperative blood loss or inflammatory response, further compared with tranexamic acid alone. This randomized placebo-controlled trial consisted of 179 consecutive patients who underwent primary total knee arthroplasty. Patients were randomized into 3 interventions. Group IV received intravenous low-dose epinephrine plus tranexamic acid. Group TP received topical diluted epinephrine plus tranexamic acid. And Group CT received tranexamic acid alone. The primary outcome was perioperative blood loss on postoperative day 1. Secondary outcomes included perioperative blood loss on postoperative day 3, coagulation and fibrinolysis parameters measured by thromboelastography, inflammatory cytokine levels, transfusion values, rate and volume, thromboembolic complications, length of hospital stay, wound score, range of motion, and hospital for special surgery HSS score. The mean calculated total blood loss and standard deviation in Group IV was 348.1 plus or minus 158.2 milliliters on postoperative day 1, and 458.0 plus or minus 183.4 milliliters on postoperative day 3, which were significantly reduced at p less than 0.05 compared with Group TP at 420.5 plus or minus 188.4 milliliters on postoperative day 1, and 531.1 plus or minus 231.4 milliliters on postoperative day 3, and Group CT at 520.4 plus or minus 228.4 milliliters on postoperative day 1, and 633.7 plus or minus 237.3 milliliters on postoperative day 3. Intravenous low-dose epinephrine exhibited a net anti-inflammatory activity in total knee arthroplasty and did not induce an obvious hypercoagulable status. Transfusion values were significantly reduced at p less than 0.05 in Group IV, but no significant differences were observed in the incidence of thromboembolic complications, wound score, range of motion, and HSS score among the 3 groups at p greater than 0.05. Conclusions. The combined administration of low-dose epinephrine and tranexamic acid demonstrated an increased effect in reducing perioperative blood loss and the inflammatory response compared with tranexamic acid alone, with no apparent increased incidence of thromboembolic and other complications. Next, you'll hear a commentary by Dr. Raphael J Sierra on the article entitled Low-Dose Epinephrine Infusions and Tranexamic Acid During Lower Extremity Total Joint Arthroplasty.
This is Dr. Raphael J Sierra providing commentary for the February 2018 JBJS podcast. I will be providing commentary on the article entitled Low-Dose Epinephrine plus Tranexamic Acid Reduces Early Postoperative Blood Loss and Inflammatory Response, a randomized controlled trial. The title of my commentary is Low-Dose Epinephrine Infusions and Tranexamic Acid During Lower Extremity Total Joint Arthroplasty. In this article, Zheng et al. Published a randomized controlled trial exploring the benefits of adding low-dose intravenous epinephrine to tranexamic acid as a blood conservation strategy during total knee arthroplasty. In their investigation, all 3 groups of patients received 1 gram of intravenous tranexamic acid at incision and 3 grams of dilute topical tranexamic acid at closure, and were randomized to receive low-dose intravenous epinephrine, topical epinephrine with the topical tranexamic acid, or placebo. The primary outcome was perioperative blood loss on postoperative day 1. The secondary outcomes included perioperative blood loss on postoperative day 3, transfusion rates, and measurement of perioperative anticoagulation and fibrinolysis parameters using thromboelastography. The authors report decreased blood loss in those patients receiving low-dose intravenous epinephrine compared with the other 2 groups. In addition, the low-dose intravenous epinephrine group exhibited a net anti-inflammatory activity, a significant reduction in early postoperative pro-inflammatory cytokine levels, except interleukin-6 and interleukin-8, and increased early postoperative anti-inflammatory cytokine levels. Decreased blood transfusion was also observed in the low-dose intravenous epinephrine group. Total knee arthroplasty has historically been associated with substantial blood loss. Transfusion rates for total knee arthroplasty have decreased significantly in conjunction with blood conservation strategies that include tranexamic acid. Both large prospective randomized trials and meta-analyses have demonstrated the efficacy and safety profile of tranexamic acid and reductions in blood loss and transfusions without increased risk of thromboembolic disease. At published doses, tranexamic acid is well tolerated and safe in most patients, with reported adverse events being exceptionally rare. In the current study, Zheng et al. Investigate the additional beneficial impact on blood loss, transfusion, and inflammatory markers of adding low-dose intravenous epinephrine infusion to a tranexamic acid protocol. The authors found favorable outcomes across these measured endpoints and concluded that reductions in pro-inflammatory cytokines during the first 6 hours postoperatively may play a role in reducing swelling, pain, and infection. The use of epinephrine in elective surgical procedures, as well as its various physiologic implications, merits deeper consideration. Decades of research on epinephrine as a procoagulant have demonstrated key activities associated with increased fibrinogen release, activation of fibrinogen receptors, and effects on other coagulation factors whose activities are mediated through beta-adrenergic mechanisms. Further research has demonstrated that platelet count increases arrive from splenic autotransfusion following low-dose epinephrine infusion. Thus, changes in procoagulant activity and platelet number occur in addition to the antifibrinolytic mechanisms of tranexamic acid. In a recent randomized trial by Jans et al. In patients who underwent total hip arthroplasty and received tranexamic acid, those patients who received low-dose intravenous epinephrine had a significant decrease in blood loss at 24 hours compared to those patients who received placebo. All patients in that study received spinal anesthesia, wherein an additional clinical advantage in terms of hemodynamic support may be realized with the use of noradrenaline. The clinical use of a potent catecholamine to gain specific outcome gains, such as bleeding and inflammation, must be seen in the context of other systemic implications and local risks. For example, epinephrine, because its alpha and beta-adrenergic receptor activity, may place considerable cardiovascular stress upon patients. Thus, exclusionary criteria in the study by Zheng et al. Included cardiovascular and other conditions with the capacity to influence conduction pathways, pheochromocytoma, thyrotoxicosis, digoxin therapy, and others. In addition to those notable exclusions, Zheng et al. Only included patients who were less than 65 years of age, so the risk of using a low-dose intravenous epinephrine infusion in patients who were older than 65 years of age undergoing total knee arthroplasty is not known, and the results of this study should not be generalized. The benefits of low-dose intravenous epinephrine go past its ability to decrease blood loss. Sharrock et al. Randomly assigned 30 patients undergoing total hip arthroplasty under epidural anesthesia to receive either epinephrine or phenylephrine. The epinephrine group was able to maintain an appropriate heart rate and cardiac index compared with patients who were receiving phenylephrine infusions. In the anesthesia literature, low-dose intravenous epinephrine has been used since the early 2000s during cesarean delivery, especially if a spinal anesthetic is required. Nanki et al. Demonstrated the superiority of norepinephrine over phenylephrine infusions at maintaining heart rate, blood pressure, and cardiac output during cesarean delivery. In total knee arthroplasty and total hip arthroplasty, the benefits of low-dose intravenous epinephrine may be more profound when a spinal anesthetic is used. Spinal anesthesia during total knee arthroplasty similarly produces a sympathectomy and a drop in heart rate, blood pressure, and cardiac output. Propofol administration adds additional cardiovascular depression and reduction in perfusion pressures. There are data demonstrating that intraoperative mean arterial pressures of less than 55 millimeters of mercury are associated with an increased risk of myocardial and renal injury. The use of low-dose intravenous epinephrine may actually counteract the negative hemodynamic parameters associated with spinal anesthesia and may support cardiac output and organ perfusion. Finally, the administration of low-dose intravenous epinephrine requires considerable caution with regard to the risk of tissue necrosis from intravenous extravasation. Thus, intravenous administration without central venous catheters requires delivery of dilute concentrations through a large-bore intravenous line in the visually monitored extremity. Epinephrine may also increase risk of arrhythmias, myocardial ischemia, or thromboembolism. Therefore, patient selection is critical. Although epinephrine is a relatively inexpensive medication, dosing errors and the cost of administration are additional considerations.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled The Cost of Joint Replacement, Comparing 2 Approaches to Evaluating Costs of Total Hip and Knee Arthroplasty by Dr. John A. Palsy and Associates. Investigation performed at the Medical University of South Carolina, Charleston, South Carolina. In an era of mandatory bundled payments for total joint replacement, accurate analysis of the cost of procedures is essential for orthopedic surgeons and their institutions to maintain viable practices. The purpose of this study was to compare traditional accounting and time-driven activity-based costing, TDABC, methods for estimating the total costs of total hip and knee arthroplasty care cycles. The authors calculated the overall costs of elective primary total hip and total knee replacement care cycles at their academic medical center using traditional and TDABC accounting methods. They compared the methods with respect to the overall costs of hip and knee replacement and the cost for each major cost category. The traditional accounting method resulted in higher cost estimates. The total cost per hip replacement was $22,076, 2014 US dollars, using traditional accounting, and was $12,957 using TDABC. The total cost per knee replacement was $29,488 using traditional accounting, and was $16,981 using TDABC. With respect to cost categories, estimates using traditional accounting were greater for hip and knee replacement, respectively, by $3,432 and $5,486 for personnel, by $3,398 and $3,664 for space and equipment, and by $2,289 and $3,357 for indirect costs. Implants and consumables were derived from the actual hospital purchase price. Accordingly, both methods produced equivalent results. Conclusions. Substantial cost differences exist between accounting methods. The focus of TDABC only on resources used directly by the patient contrasts with the allocation of all operating costs, including all indirect costs and unused capacity, with traditional accounting. The authors expect that the true costs of hip and knee replacement care cycles are likely somewhere between estimates derived from traditional accounting methods and TDABC. TDABC offers patient-level granular cost information that better serves in the redesign of care pathways and may lead to more strategic resource allocation decisions to optimize actual operating margins. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.